In this video, we are going to discuss about mitral regurgitation. Mitral regurgitation is basically due to the improper closing of mitral valve during ventricular systole. That will lead to backflow of blood from left ventricle into left atrium during systole. So mitral regurgitation is backward leakage of blood from the left ventricle into the left atrium during ventricular systole due to incomplete closure of mitral valve. That is systolic retrograde flow from LV to LA. We can classify it as acute MR, chronic MR. Acute MR can be due to rupture of papillary muscle, or it can be due to rupture of chordae tendineae. Chordae tendineae rupture is seen in case of infective endocarditis. These are the papillary muscle. Two groups of papillary muscle we have, that are anterolateral papillary muscle and posterolateral papillary muscle. Anterolateral papillary muscle is supplied by both left carotid artery and right carotid artery, but in posterolateral papillary muscle it is only supplied by right carotid artery. So in case of inferior valve MI, where right carotid artery is involved, that will lead to ischemia or necrosis of the posterolateral papillary muscle. That will lead to rupture of posterolateral papillary muscle, and that will lead to development of acute MR. So rupture of papillary muscle or rupture of chordae tendineae, it can lead to development of acute MR. So what is chronic MR? It can be due to primary MR or secondary MR. Secondary MR is functional MR, like we have discussed functional tricuspid regurgitation in case of mitral stenosis due to right ventricular hypertrophy and annular dilatation. That was functional TR. In case of long-term MS, here it is functional MR. Functional MR, that is MR begets MR. It is a vicious cycle due to LV dysfunction and annular dilatation. MR, there will be volume overload that will lead to left ventricular dilatation, mitral annulus dilatation, poorer left leaflet coaptation, and more development of MR. So this MR begets MR. It is a vicious cycle. Other causes are hypertrophic cardiomyopathy due to systolic motion of anterior leaflet, SAM. Systolic anterior motion leaflet. Systolic motion of anterior leaflet, SAM. It can also lead to development of functional MR. What are the causes of primary MR? Most common cause of primary MR in developing countries is rheumatic heart disease. Most common cause of primary MR in developed countries is mitral valve prolapse. Other causes of MR like autoimmune disorder like SLE and RA. So chronic MR in rheumatic heart disease, 15 to 20 years after, there will be development of both MS and MR. Organic or primary MR, abnormality of valve apparatus. Functional MR due to secondary LV dysfunction, that will lead to annular dilatation and MR. It is MR begets MR. Chronic secondary MR, LV dysfunction, annular dilatation, LV dysfunction, MR begets MR. In MR, we have to control the blood pressure tightly, because increase in BP lead to increase in aortic pressure that will transmitted into left ventricle, because when there will be increase in systemic blood pressure, the aortic pressure will increase, there will be increase in afterload, so it will be difficult for the left ventricle to pump blood through the aorta. So it will backflow the blood into left atrium if there is regurgitant mitral valve. So you have to control BP tightly, because BP increase lead to backflow to LA from LV. Due to increase in aortic pressure, it can lead to severe MR. So you have to control BP tightly in case of mitral regurgitation. Nitroglycerin or nitroprusside, they are life-saving in acute MR, because they are the agents which cause systemic vasodilatation or decrease the afterload. Decrease the afterload, more blood flow towards the aorta instead of flowing to the left atrium through the regurgitant valve. So pathology, mitral regurgitation, coaptation zone is not formed completely, that will lead to soft S1. All the valvular heart disease lead to soft S1 except MS. In MS, if there is calcific valve, that can also lead to soft S1 due to incompetence of the valve leaflet, leaking of blood from LV to LA. This is basically what happens in case of MR. So MR is a volume overload state. The remodeling of MR is eccentric left ventricular hypertrophy with increase in left ventricular radius and a little increase in left ventricular thickness. So the LV thickness is increasing, but it is very less as compared to left ventricular radius. In case it is called eccentric hypertrophy and dilatation. But in case of aortic stenosis, we see concentric hypertrophy, where the thickness is increasing but the radius is not increasing. Here the radius is increasing but the thickness is less increasing. So it is eccentric hypertrophy or dilatation, contractility of left ventricle is impaired. There will be LV systolic failure due to this only. So severe MR, LV failure, that will lead to annular dilatation and it will lead to further MR, and this vicious cycle will continue. So difference between compensated and severe MR. So compensated MR is mild to moderate MR. If patient is asymptomatic, it can present with palpitation or fatigue. Ejection fraction is normal or increased. Left ventricular end diastolic pressure is normal. Left ventricular end systolic pressure is normal because it is compensated by left ventricular eccentric hypertrophy and dilatation. In case of severe MR, it is decompensated MR. There will be LV failure. When LV failure occurs, there will be increase in left ventricular end diastolic pressure. That will lead to increase in left atrial pressure. That will lead to increase in pulmonary capillary rise pressure. That will lead to dyspnea. Ejection fraction can be normal or decrease, and left ventricular and systolic pressure also increase in case of severe MR. So normal ejection fraction is MR is 70%. If it is less than 60%, it needs treatment. So what are the clinical findings in case of MR? We have pseudo collapsing pulse. Collapsing pulse found in case of AR. It is rapid upstroke, rapid downstroke with ill sustained peak, and it is high volume. But pseudo collapsing pulse, which is found in case of MR, rapid upstroke, rapid downstroke, but it has well sustained peak and it has normal volume. So what happens to blood pressure? In case of severe MR, there will LV systolic failure, that will be low BP and decrease in systolic blood pressure, and that will lead to narrow pulse pressure. Apex is down and out, hyperkinetic apex. JVP, V wave will be more prominent in case of tricuspid regurgitation. MR has no relation with JVP, but in case of tricuspid regurgitation, V wave is more prominent. V wave is basically due to motion of the tricuspid valve while the right ventricle is contracting. If the tricuspid valve is regurgitated, then there will be more motion of this tricuspid valve into the left atrium. That will lead to positive wave in JVP, that is the V wave. So it is more prominent due to tricuspid regurgitation. So what happens to heart sound? S1 is soft because the pressure across the valve is decreased, dP by dt is decreased, so there will be soft S1, and there is a volume overload state, so valve is floating in the blood. That is another cause of soft S1. S2, during systole, blood flows back into left atrium. That will lead to decrease in preload. So during systole, blood is going back into left atrium. That will lead to decrease in preload. So that will lead to faster emptying of left ventricle and earlier fall of left ventricular pressure below the aortic pressure, so that aortic valve closes early. So S2 can be early. That will lead to wild split due to early A2. So S2 is A2 P2. Here the preload in the left ventricle is decreasing in case of MR because the blood is flowing back into LA. That will lead to decrease in preload. That will lead to early closure of the valve. That will lead to early A2, and it can lead to wild split of S2. So in AS aortic stenosis, we found heaving apex. In mitral stenosis, we found tapping apex. But in case of AR and MR, we found hyperkinetic and down and out apex. MS tapping apex, AS is heaving apex, AR and MR hyperkinetic or hyperdynamic down and out apex. So normally A2 P2, because RV takes longer to eject blood against the low resistant pulmonary circulation, physiological splitting of S2 occurs during respiration. Here the split can be more prominent in case of MR. So S3 suggests significant MR due to LV volume overload due to rapid filling of left ventricle during early diastole. So S3 is a sound of failing heart. If there is development of left ventricular failure due to long term MR, S3 can be heard there. So S4 is absent. S4 is only present in case of AS. So it is seen when LA contract against stiff non-compliant left ventricle. That is in case of aortic stenosis. But in MR, the main problem is volume overload with a compliant and dilated left ventricle, not a stiff ventricle. Here in MR, the left ventricle is compliant and it is dilated. It is not stiff. If it was stiff, then we heard S4. When atria contract with against a stiff ventricle and the valve is normal, the valve is not stenosis, then only we heard the S4. That is heard only in case of aortic stenosis, and it is never heard in case of mitral stenosis because the valve is stenosis there. In MR, the ventricle is non-compliant. It is dilated, but it is not compliant. So murmur, that is heard in case of mitral regurgitation in pansystolic murmur. Pansystolic murmur is heard in other conditions like ventricular septal defect, tricuspid regurgitation, mitral regurgitation. So acute MR, short decrescendo systolic murmur. Short decrescendo systolic murmur is heard in case of acute MR. So this murmur of mitral regurgitation is best heard at apex in left lateral position with breath held in expiration using diaphragm of the stethoscope. Loudness of murmur correlate with severity. Loudness that is proportional to pressure gradient. So character is high frequency, soft blowing murmur without any thrill. It radiates to axilla and it can radiate to back also. So MR murmur most commonly radiates to axilla. Management is indication for treatment is symptomatic patient, asymptomatic patient with 60-40 rule. In case of AR, we discussed 55-50 rule. Here we discuss 60-40 rule. 60-40 rule says that ejection fraction less than 60%, left ventricular end systolic diameter more than 40 mm. That is an indication of surgery or treatment in case of mitral regurgitation. Left ventricular end systolic diameter is the diameter of left ventricle at the end of systole. So mitral valve repair is greater than mitral valve replacement. So post mitral valve repair, there is sudden increase in afterload that leads to LV failure. So chronic MR, LV adapts to dilatation and eccentric hypertrophy, so it is compensated high stroke volume. But if you replace the mitral valve or you treat it mitral valve replacement or we do the treatment of mitral regurgitation, there will be sudden increase in effective afterload because now the ventricle has to pump blood only towards the aorta because the low pressure pathway which has the towards the left atrium, now it is not there because we have repaired the valve, so it have to only pump against the aorta. So LV cannot eject it easily, so forward stroke volume decreases, LV and systolic volume increases, that lead to acute left ventricular systolic failure. In chronic MR, LV has two outlets. The aorta is high resistance and the left atrium is low resistance. So blood can easily escape into LA and the LV appears to pump well. But after mitral valve replacement, this easy low resistance route is suddenly closed. So all the blood must now pump into the aorta against the higher resistance. If LV muscle has already become weak due to long-standing MR, so it cannot handle sudden increase in workload, causing LV systolic failure and fall in ejection fraction. So after mitral valve replacement, we can encounter LV systolic failure and fall in ejection fraction. So this is all about mitral regurgitation. These are some basic things. These are the areas. We have aortic area. Aortic area is second right intercostal space at right sternal border. This is the aortic area. Second right first intercostal space, second intercostal space, second right intercostal space at right sternal border. We have the aortic area. Aortic area we can heard A2 and murmur of aortic stenosis, that is ejection systolic crescendo decrescendo murmur. And other area we have that as pulmonary area. Pulmonary area is second intercostal space left sternal border. Second intercostal space right sternal border is aortic area. Second intercostal space left sternal border is pulmonary area. So this is pulmonary area. Second intercostal space on the left sternal border. This is the pulmonary area. We can heard here P2 and pulmonary stenosis murmur. Then what is Orr's point? Orr point is also known as new aortic area. It is third left intercostal space. Third left intercostal space sternal border. So in first intercostal space, second, third intercostal space, near the left sternal border we have neo-aortic area or Robb's point. Here we can heard the murmur of aortic regurgitation. And mitral area, it is fifth left intercostal space, mid clavicular line. In the mid clavicular line, fifth left intercostal space, we have mitral area. Here we can heard M1, murmur of MS and murmur of MR. This is heard in mitral area. Mid clavicular line, fifth left intercostal space. In tricuspid area is left lower sternal border, fourth, fifth intercostal space. Here you can heard murmur of tricuspid regurgitation, which increases with inspiration, that is called Caravello sign. Now discuss about acute MR. So acute MR is due to, we discuss rupture of papillary muscle or rupture of quadrant tendinae. It can be due to inferior MI, RCA occlusion. It can be due to infective endocarditis also. So acute regurgitation into non-compliant LA. Here the LA is non-compliant, so that will lead to sudden rise in left atrial pressure, giant V wave in JVP, it is happening in the right side. Increase in left atrial pressure lead to increase in pulmonary capillary wedge pressure, that will lead to pulmonary edema or congestion in the lung, that will lead to dyspnea, acute development of pulmonary edema. So in acute severe MR, a large fraction of blood suddenly takes easier route into left atrium. LV stroke volume decreases, that will lead to decrease in cardiac output, that will lead to cardiogenic shock, low BP, cool extremities, oliguria, altered sensorium. Murmur is short systolic decrescendo murmur, managed by nitroglycerin nitroprusside, that will lead to decrease in afterload, and it will decrease the flow of blood from LV to LA. Till intervention, we have to keep the patient on vasodilators. So emergency intervention is surgery. So it is like just like acute AR. There are also we have decrease in stroke volume, that will lead to decrease in cardiac output, that will lead to cardiogenic shock, low BP, cool extremities, oliguria, altered sensorium, and these are the forward symptoms. Backward symptoms are due to increase in left atrial pressure, increase in pulmonary wedge, capillary wedge pressure, that will lead to dyspnea. So this is all about MR.